is to have the aim here, of improving our advocacy, the advocacy of us as landscape architects, for better recognition of the health benefits of green infrastructure, because obviously there's a lot of environmental service benefits and other benefits, but what about the health benefits? And there, how do we forge stronger alliances with public health professionals who are often situated, well, more and more in local authorities since moving in 2013 from the PCTs into local authorities. I'm in a unitary council here, so I think they sit in the higher tier local authorities if you're in dealing with two-tier authorities. So that's the aims. And in terms of the content, just to run through some useful concepts here, and I hope I'm not sort of coming at too low a level here, some useful concepts, and the usefulness is the nuance of the concept, and I'll talk about that. Then look at the state of knowledge. How do we get the state to the state of knowledge, and for those bits of evidence base that will really make that difference in public health, or in releasing funding, or in people getting up and saying, hey, there's an issue here that we need to do more in terms of population health, community health through green infrastructure. So a bit on the state of knowledge. And finally, on the local leverage, some of the mechanisms, some of the, particularly in local authorities, how they operate, what are the targets they've got to meet that will give us leverage, and then the arguments that can win. So go straight in with the concepts, and I'm going to go through what is health. You might think this is quite simple, but still there's the definition of health that gives us traction, and there's definitions of health that don't. The wider determinants of health, and this is incredibly important, and even though I've been in this field for 15 years, this is becoming more and more important, is the wider determinants of health and that concept. And we'll talk about why that's becoming more and more important. And to go through non-communicable disease, because that's a term that we should be able to pronounce, non-communicable disease, trip off our tongues, because that's where we're situated. That's what we're talking about here, certainly in working in developed cities, developed urban places. If you're in the third world more, you could be talking about communicable disease. Or if we were going back 200, 250 years in urban form, we might be talking about communicable disease. And what is public health? And again, we need to know, if we're going to connect with public health, what their definition of their profession is, what do public health practitioners think they're put on earth to do, if you like. So health, I think this is always a good place to start. Health is a state of complete physical, mental and social well-being, and not merely the absence of disease or infirmity. And that's actually enshrined in the Constitution of the World Health Organization, 1948, 192 signatory countries, we're a signatory to this. So we buy into that at various levels, that's the definition of health. And you can sort of track that through the National Planning Policy Framework as well, back to that definition, although it does get buried under the sort of more NHS health as curing people all the time debates. Public health will buy into this definition of health, although sometimes they forget that and it's about smoking, teenage pregnancy, etc., etc. But that, I think that is all covered under that complete physical, mental and social well-being. Once we have that definition, it unlocks the agenda really for how green infrastructure can support health. And that's where we come on to the wider determinants of health. And this is based on work from 1991, Whitehead and Dahlgren, who actually did a piece of work for the WHO looking at what they called at that stage the social determinants of health. Also, yeah, and the wider determinants of health. I'm sort of honing in on the idea of the spatial determinants of health being the field that we could show expertise in. And this diagram then places people at the center, and people come with their own health factors, if you like, through their age, sex, hereditary factors. But whether these factors express in ill health or not will be determined by their lifestyle. And there we've got that inner row sort of around the people as we're moving out there. Diet, physical activity, work-life balance, for instance. These are just examples. But to have a good diet, you need to live in a place with local shops, and to have physical activity, you might need to live in a place where there's treed streets, where there's a convivial, livable public realm. To have work-life balance, what does that say about the commuting distances, about the way we shape towns and cities, about mixed use, etc. So actually, people aren't free to choose any lifestyle. The lifestyle is constrained by the spatial environments people find themselves in. And equally, those spatial environments could determine the level of community support, social capital, networks. I often think of the, I think it's the 2006 heat waves in France, and huge numbers of deaths brought forward of old people. And only, is it the heat that killed them? Or is it because they were isolated and didn't have neighbours who were looking out for them to bring them a drink, to help them through that time? So social isolation, and I read in the papers, it's becoming more and more recognised, particularly in vulnerable groups, particularly the elderly, but it could also apply to people left at home with caring responsibilities in places with where the physical form of the place doesn't support community interaction. So there's this sort of mediation always of the built environment. Skipping onto the dark blue arcs in this is where we operate really. We're operating in built environment and natural environment, interventions there. Of course, the interventions there are modifying then the activities that modify the local economy, the community, the lifestyle, and interact with and either disbenefit or benefit health. So we use this as very much a diagram, the terms of health diagram, to capture health impact. And you can capture, if you have an intervention, a new park, or upgrading a park, or replacing street trees, you could almost capture what it might do to people's health using this diagram. So if you work in towards the centre, you're working in towards people, individual health, and more evidence, there's more and more evidence base that an intervention in any one of these arts can affect people's health. You don't have to go through every single sort of layer before you get to the health impact. Equally, what this diagram does very well, and I think this is quite poignant for green infrastructure and health, is that almost the green on the outside global ecosystem, you see then the general infrastructure, green natural infrastructure in which humanity is based, our health is based and situated. So if you work the impacts outwards, you get the impacts on sustainability, ecology, climate stability, biodiversity. And as the Millennium Ecosystem Assessment demonstrated, those global impacts impact back on our health. So the Millennium Ecosystem Assessment, and I don't know how many of you've seen this as well, this is very good for looking at those links between what they call ecosystem services and constituents of well-being. So here we have the ecosystem services, the supporting, provisioning, regulating and cultural services that are derived from green infrastructure. And then on the other side in the blue you have constituents of well-being, and tracking through from aspects of green infrastructure that we can see that we might be working with there, to do with flood regulation, aspects to do with climate regulation, food provision, etc. And you can track through to how that impacts on well-being. And have health there in a box, that's because I think they're using more of a medical definition of health there, and where it says constituents of well-being, that would be that wider health that we were talking about at the beginning as the definitions of health. So just have a look at that for a minute about how that interacts. So that's really a good and sort of validated model, if you like, that can be used. So moving on to non-communicable disease. So this diagram shows selected causes of death in the 20th century. As you can see, infectious diseases, I'll move it along the screen in a minute. Infectious diseases there, 1,680 million. And that, you know, these were writ large, obviously, before the sort of revolution in water provision, in sanitary conditions, etc. Cancer down there is more and more evidence that a number of cancers are, the risk of those cancers are to do with a sedentary lifestyle. So we can count some of the cancers which are non-communicable as related to the built environment. You might not be able to see it on the screen, depends how big your screen are. Then they've got a little box there, health complications, sort of things like birth defects, perinatal conditions, maternal conditions needn't interest us in this present discussion. And then as we just move through, this is still all on the same big chart. We come to accidents, humanity, cardiovascular diseases, and then this big one, non-communicable diseases, which is bigger than the bubble for communicable diseases in the 20th century. So there we've got almost 200,000 million. Reading around it, you've got diabetes, mental illness, digestive illness, respiratory disease, the very big one, cardiovascular disease. And of course, some of these are targets in the UK and will be targets with your local health and wellbeing boards. Humanity, just to read around in case you can't see some of the things there. This is the deaths that we cause ourselves, if you like, wars, ideology, murder. But interesting one there, air pollution, which obviously can be laid to some extent at road traffic, also other forms of air pollution, but in towns, road traffic is a major cause of the air pollution. So that's what we're talking about with non-communicable diseases. And just to finish up with these concepts, definitions, concepts, public health practitioners, there's a medical route-way and a non-medical route-way into public health, into becoming a public health profession. These are very highly regulated. There's a very strict and monitored CPD requirement that you have to go through every year, that's very strongly audited because it's linked, allied to the medical professions. But public health practitioners see their purpose as, he's got this fourfold purpose. One, improving health and well-being in the population. And the word there, the interesting word is population. They deal a lot with individuals as well, but actually the focus of public health comes from population level. So similar to that, there's a sort of great synergy in the way that we work. We're working with communities, if you like. We don't tend to work with the individual unless you're a garden designer or, you know, working in a very particular way with a client. You're sort of working with communities, subpopulations, people in the local area, users of an office block, users of a square, a public realm, a street. So we're both working with populations. Improving health and well-being, well, I think we've subscribed very much to the well-being. Prevent disease and minimize its consequence. So again, in those non-communicable diseases, that's what they're trying to do. Prolong valued life, which is interesting because towards the end of life, I haven't got time to show you the charts and graphs here, but if you look at the life course, we've extended the length of people's lives, but not necessarily the extent of the valued life. And there's a period of 8 to 10 years at the end of life where if you live in a community, a physical area that's not conducive to social capital, where you wouldn't know your neighbours, you're stuck up a cul-de-sac, there's no local facilities, the streets are hostile to pedestrian activity, maybe there's no allotments, there's no way of sharing outdoor space, no local parks, you're more likely to need health and social care provision and services, and your quality of life will be less. So at the end of life, and that's the aging population is becoming more and more important, I think we've got a lot to say there about prolonging valued life and quality of life at that end. And the final key purpose of public health, which often doesn't really get talked about, is reducing inequalities in health. A very interesting study, Mitchell and Popham, published in the Lancet 2006, showed that a local park has a disproportionate benefit on uplifting the health of disadvantaged more than advantaged people around it. Because the advantaged people don't necessarily need the local park. They can afford their gym membership, they can go out to their dachas, their summer houses, or, you know, they can get out of the situation. The local people, the vulnerable local people and people at lower socioeconomic group benefit more from improvements in a local park, from improved access, improved maintenance, you name it, improved design. So that's a way of reducing inequalities in health, and that's a key purpose of public health, is to reduce those inequalities. So to what degree are some of these outcomes actually in the hands of landscape architects, not in the hands of public health practitioners? I think we've got a role to play here, and this is where the sort of collaboration comes in. So that's just winding up or ending on the useful concepts. We've looked at the definition of health, looked at the wider determinants, the idea of non-communicable disease being a good term that public health will understand. Instead of us just talking about health, well, this is what we're interested in. You've got targets to reduce non-communicable disease, obesity targets, asthma targets, etc. And then what public health are about. So moving on to number 2, the state of knowledge. And I was wondering how to convey this to you. And you know, I've done a number of evidence reviews and systematic reviews, and that edge of knowledge is continually moving. And you know, we could go on for hours about that. And I think the best thing to do would be to have a few pointers to where you can find extra information. I mean, this is just a single screen showing health and well-being benefits of biodiversity and nature, passive. So this isn't being active, this isn't chopping down trees or green gyms. This is just the passive way that these can support health and well-being, and these are all evidenced, and there's some references to the evidence at the bottom. For instance, it's evidence that green transport networks support active transport. What that means is that if you have a greener active transport network, I'm talking about just a street here, or cycleway, off-road, whatever, it will support that. More people will cycle down a cycleway that has some greening, a verge, or trees, or views into back gardens than if it doesn't. Simple. Access to green spaces is related to physical activity levels. So there's higher levels of physical activity, and that can include informal or everyday walking, as well as organised activity if there's more green spaces in an area. And what we find, again, evidence shows that there's improved effectiveness of physical activity when it's in green space. So if someone's exercising or walking, whatever that chosen physical activity is, if it's in green space, it'll have improved effectiveness in terms of its health effect. Improved air quality and resistance to climate change is obvious there from a well-treed environment, from an area with a lot of green infrastructure. And then so we can go on through mental health and well-being. So those are all related to physical, mental health, the restorative benefits from psychophysiological stress, improved livability of an area, and less isolation. So more people inhabit the public realm if there's a lot of green infrastructure there, or if we're using green infrastructure, which might have a functional, technical functional ecosystem service, but we actually also use it to make the urban environment more livable. And more people will inhabit that public realm, less isolation, better social capital, eyes on the street, passive surveillance, all those things come as benefits as well. If you want to look at this in more detail, just looking down at the timing there, in more detail, these are some good websites. The American Society of Landscape Architects there have a very good and searchable evidence base. There's an EU project that's just come to the end that will be reporting health and social benefits of nature and biodiversity protection. And there's a great consortium that runs a website called Phenotype, and they call that Health from Outside In. And on that website will unfold, if you go on that, a number of publications, of research bases, of evidence and resources. There's a lot of work being done in this area, so it's difficult to sort of capture the whole at any point in time. more work being done and more results coming all the time. There's a lot of funding going into this area. So that was a sort of the state of where we are with the evidence base. And what I want to talk through here is a couple of things on local leverage. One is mechanisms, and finally some of the advocacy. So what we need to know about in local authorities, we need to know what their public health, what the public health outcomes framework is looking like for them. There's a national public health outcomes framework, and the public health professionals through the Health and Wellbeing Board were meant to be delivering against that. And it's very useful to have a look at that and see where landscape fits in, see where green infrastructure can fit in. It doesn't fit in everywhere. There's, as I say, there's smoking cessation, there's targets on teenage pregnancies, and then you'll find targets where you're thinking, actually, good landscape here could really help people meet those targets. The other thing that I think is very useful to look at, and this varies from authority to authority, so whether you're inside the authority or working with a local authority from outside, is their joint strategic needs assessment. And this is an amalgam of needs from the health and social point of view, and sometimes some of these joint needs strategic assessment go so far as looking at need in terms of access to, there could be access to parks, there could be access to allotments there, access to green infrastructure. I don't know, it's different in different parts of the country and different ways that public health are working with these, but that can be a tool, a mechanism to have a look at. Can you help provide data? Can you help provide targets that are in the joint strategic needs assessment? The health and wellbeing boards, these are all constituted quite differently, and again, some of them have more of a focus on the wider determinants of health than others. If you're working in an authority where there's a link through to wider determinants of health or spatial determinants of health, it's a real win-win. If you're in an authority, and there are many that don't, again, they're very close on traditional public health, very tight outcomes, and it's difficult to get a look in. The Director of Public Health is an important person, and the team around them. They have consultants in public health around them. In Bristol, we've had a series of Director of Public Health running through, unfortunately, in the last 5 years. We've lost a bit of traction, but there's a consultant who has just been appointed who will be looking at the wider determinants, who will be looking at activity, physical activity, and access to food. And obviously, that's our port of call relating to their targets. And finally, neighbourhood plans can be a good entry point. If you're working from the community upwards or trying to convince the community, it's looking at the degree to which the arguments with communities are really about, you know, do you want to see a place that is really fit for your healthy lifestyle, that doesn't hinder a healthy lifestyle for you, your family, for you as you get older? I think there's a lot of community traction in that. So if you're working with neighbourhood plans, there's a huge, or neighbourhood planning, there's a huge entry point there for this agenda, because in the end it's about livability and health, and local people often are very keen on these arguments. Going back to the arguments, this is, I just want to go through 3 bits of argument here, just as we're in the last 5 minutes. A causal link, about causal links, and public health are very keen on causal links. Saving the NHS, where do we fit in there? And just to run through the Landscape Institute Public Health Position Statement, which has some examples. So, causal link, basically, when you're working with public health, because it's a very medical, it has a clinical basis for its science, they're basically often saying there's no causal link, or they're saying a causal link hasn't been found, therefore there's going to be no funding, we're not interested in it. We're not interested in greening an area, we're not interested in better access to the local park, we're not interested in using a shelter belt to protect the allotments and also have a cycleway running through it, whatever it is. They say there's no evidence. What they mean by that is no evidence has been found using a very rigorous and reductionist scientific method. It doesn't mean there isn't evidence. It's within their narrow definition of evidence, and they use the still unfortunately use the randomized controlled trial at the top of the evidence. So basically you need to randomize all the babies who are born without them knowing, put some into a town that's full of green infrastructure, put others to grow up in a town that isn't, and then, you know, as they live out their lives, you look at who's going to hospital, how long they live, and then you've got your randomized controlled trial. It ain't going to happen. What we're saying is there's associations, because we're working in a whole system. It's much more the strong associations between good health, good well-being, and the sorts of places that have green infrastructure. That can be a tough one to make, but that's where they're coming from on the evidence base. But also they're saying, well, there's no causal link, so there's no funding. But I'm wondering, well, to what degree you need funding, because funding in public health is funding a program. It's a program of anti-smoking. It's a program of teenage pregnancies. Sorry, I keep on going on about those. But then you have a program that's funded for, you know, into the future, huge expense. We're not talking about that. We're talking about getting something right for the design stage, often at the beginning or regeneration of an area, and then that's it. You're getting it right through good design. You're not pumping in money continually because something's broken. And that's a different concept, and they find that difficult to understand. There's a little bit of design work, some linkages between the right stakeholders, maybe a bit of capital, better capital quality at the beginning, and then it's sorted for a lifetime. Okay, there's maintenance and things like that as well. But it's not the same idea that they're looking for a program to fund. They love programs that they then fund. Looking at the evidence, it's quite interesting because there's evidence for what's going wrong, but, you know, do we leave it to the market? And I think you need to say that to public health. Should we leave it to the market then to build social capital and create inclusive communities? If there's no evidence, do we just, is it laissez-faire? You know, we're very good at building nice homes, and they're all tucked away behind walls and strung out local facilities. You need lots of cars, but there's no evidence base that this is good for population health. Well, that gets delivered. You don't need an evidence base for that. You know, and I think the challenge to them is how can we work together to stop delivering places that are unfit for healthy lifestyles? Do we need evidence before we can work together? I don't think so. We're looking at how the public realm affects health, and this might help. It's just that getting that link there. There's no single causal factor. It's this complex web of relationships that's obvious between certain physical factors, can limit certain lifestyles, and then have a associated health issue effect, and those are target health issues. And just to finish up, the total UK spending for the public health is running away, often with these lifestyle diseases, they're called, non-communicable diseases. And the only way to afford an NHS is actually to get in at the beginning, really, and solve these at source, not solve them with people who have the disease. And the NICE uses a cost-effectiveness graph for what they fund, and if drugs are in the red box at the top, they don't fund them. In the green box at the bottom, they do. All the things we're talking about are in the green box. All the landscape remedies for health are the cheapest, cheaper than drugs, cheaper than surgery. So to finish up with, there's a green infrastructure position statement. To recommend that to you, you've probably read it. There's the public health and landscape position statement. So it's my timer going off, so I'll just finish up. If I can switch this off. No. And so the landscape position statement, these are just running through the headlines in this position statement. And to finish up, this is again a statement from the WHO. Health is created and lived by people within the settings of their everyday life where they work, so where they learn, work, play and love. Thank you.
Hi, I'll just let you locate your timer, turn it off there.
I've done that.
Technology at its best. Thank you very much. Found that very, very interesting, actually. So we'll open the floor now, and let me just click into the questions. So now is the time If anyone has any questions to ask Marcus, the presentation bit is finished, so fire away if you want to ask anything. If you have to run off now, or if you can't think of your question, formulate it correctly now, there will be an opportunity, because as per usual, 24 hours after this finishes, you get sent an email giving you the perfect chance to feedback or ask questions, and then we can put them to not only Marcus, but anyone in our team here at the Landscape Institute that could help. Just to remind you that this is also going on YouTube, so you will have the opportunity to read it again, watch it again, share with friends, co-workers, colleagues, whatever you like. So if you have any questions, please fire away now. Or if Marcus, if you wanted to expand on some things that you thought you didn't get a chance to cover earlier, that you wanted to skip over due to timings, now is also your chance to do that.
Okay, thank you.
Would you like to start with anything that you want? You were skipping over a slide earlier, the timings wise, but I didn't know if you wanted.
I think I just would have gone into more detail, maybe on the, but just through reading out really the position statements and the Landscape Institute and the work it's done on there, and certainly the position statement on public health is, you know, very well written and provides a lot of good information there. That was all. So are there any questions?
Not at the moment, no. But I was just going to say, we as an institute are focusing a bit more on public health. Obviously, we've released a document on it already. So if anybody would like a copy of that, just let me know, and I can send that out to you after this, or a stack of them if you need them for your practice. Obviously, we're the American Association of Landscape Architects. You referred to their website afterwards, that they've done a body of work on it. And as you say, in this country, we're kind of getting back up to speed with it. There's a lot of funding, there's a lot of interest. Finally, the recognition is there that, you know, how important and wide-reaching it is, and we will be doing more and more on it. So just to kind of champion the British.
Yeah, well, quite. And the problem with some of the data on the American Association has a lot of data there, because the US got into funding research in this field about 15 years before we did. But when you drill down into the research, you will find then that it isn't totally applicable sometimes to the European model of a city. So it might be linked more to sprawl and to sort of American big lots and backyards and things like that. So it has to be used with care. There is research coming. There's some great research being done in Scotland and other parts of the UK, but it's as the sort of pucker research findings, they're not out yet sometimes.
Okay. Thanks.
So I've got a question here.
Yeah.
In my experience, health and wellbeing boards seem reluctant to get engaged in green infrastructure. They seem to focus on, yeah, on placing surgeries or health centres, but outside those buildings it's a struggle. How do you think we should engage them? Well, I think that's a very good question, and it's continually my struggle to engage them and to find the right bits of the organisation to engage with this. What I was going to say on the slide, a couple of slides that I glossed over near the end with the sort of graphs, the Wanless report, which was the graph showing how the NHS is needing more and more of GDP. Now, of course, that's not of interest to a local health and wellbeing board in a sense, but there is a bigger agenda there. And what came out of that report was that in order to afford the NHS and the NHS we want, more people have to be engaged, and I take that as professions, more professions. So there's a lot that happens for health, in health or ill health, that isn't controlled or deemed or even touchable by the public health profession traditionally. So as landscape architects, we need to convince the health and wellbeing boards that we have some of the solutions. We are part of that answer to affording better health for the population. Now, they won't want to engage in green infrastructure because they're wanting to engage in health. So it is also turning it, obviously we don't go say, we want you to fund the great design of green infrastructure. It has to come from health. So you have to grab their targets. Now, if you're talking about a health centre, I mean, with the surgery, I can talk about surgeries a bit, but if you're dealing already with the people who are dealing with surgeries and health centres, you're dealing with a bit of the wrong bit of the system. With the surgeries or health centres, the beginning discussion can be about, I mean, I'm struggling here, but not too much. It's a bit like all the adjustments that happen to someone when they're released from hospital back into their house, or an older person, and they'll adjust the house. They've got all the funding for the grab rails and the steps and the things in the chairs to make them higher so they can sit down and sit up, but nothing outside the house, nothing even in the front garden. So in the end, the person is trapped in the house. They've not thought there's parked all over the garden, and the front garden's a mess, but there's some local people wanted to use it as an allotment or whatever, or where it is, or the walk to the shops or other aspects. So similarly, by focusing just on the health centre and the surgery, you do have, in Bristol, we have a doctors group that is now looking beyond the surgery, beyond the health centre. They understand that their population, and they can only afford, to run a service if they have a healthier population, and it's not through pills, and it's not through referring them to hospitals, it's through making sure they all have a better lifestyle. And that is then about benches for old people to sit on as they go up, access to toilets and water outdoors. It's about tree landscapes. It's about getting cars off the pavement and slowing down cars on the road. It's all sorts of agendas that can link to green infrastructure. So it's but it's about convincing them that within their budgets and within their buildings they can't solve it, because the health problems that they're trying to solve are being caused outside the buildings. And this is a public health argument. It's putting the they call it putting the fence at the top of the cliff rather than the ambulance down in the valley. Basically, you can run as many ambulances down in the valley as you want, and you'll run out of money. But put the fence at the top of the cliff. So it's getting through to the right person in the Health and Wellbeing Board, the person who's looking at wider determinants, social determinants, inclusion. That's your way in. I hope that's a rather full answer. I hope that sort of answers some of it. Oh, that's a sort of anecdote on that.
Yeah, good analogy and metaphor. I like that. Okay, wonderful.
As a sort of, I just want to say as an anecdote on that, I've set up a partnership here in Bristol called, under the auspices of Bristol Health Partners, that links both the universities, the council, and the 3 acute trusts, and we're funded across that partnership. But when I go to the acute and pitch what I'm doing, I mean, the NHS has been taken to bits to such a degree that if you pitch to the acute hospitals, right, I want a healthier population, they basically look me in the eye and say, Marcus, why do we want a healthier population? It's not our business model. We cure sick people. I'm taking away their customers. That is the degree to which the NHS has now been privatized or put in little boxes. So, you've got to talk to the right bits, and public health, generally, you should get a better reception.
Interesting point. Yes. All right. Well, if there are no more questions at the moment, and you're saving yourself for the feedback form, we'll round up for the day. As I said, it will be on YouTube, which is accessible from our webinar page on our website, landscapeinstitute.org, or you can email me, lauren.tubb@landscapeinstitute.org, or there'll be an automatic email whizzing itself to your inbox tomorrow. So thank you for listening. Thank you for your question, Tim, and thank you for joining us next week. Thank you, Marcus. Goodbye.
Okay, thanks everyone. Bye.